All right, everybody. Hello out there. Ah, it's okay. Let me know. I'm user friendly. It's a chatty class today. It's Friday, I know. Ladies in the back, okay? I do it to everybody. Yeah, without. Thank you. Thank you very much. So I just look at everybody. I used to have that, and everybody would stop if I lost it somewhere along the road. Without further ado, so some again bookkeeping. So there's not a lot next week other than the doing the blood lab. I don't really want to go crazy starting a lot of new stuff with the break forthcoming, and I have to sort of overlap respiratory a little bit. I mean, so after the break, I'm going to start immune. I'm going to do a little bit of respiratory for two reasons: before the break and after the break, because we'll do the respiratory lab when we come back from the break, whatever day that is. Whatever, was that the 18th? Yes. Cool. So all things being considered, that's kind of how we're going to do that. And the respiratory lab is one of those tech labs, but it's fun because it's really about you trying to, we're going to try to calculate vital capacity, or what's called forced vital capacity. So I do want to introduce that a little bit and get the respiratory physiology, because immune I try to do as a standalone unit. And I will start that in lecture when we come back. Maybe just tidying up some respiratory stuff at the same time. That's what I have to announce for you. So a couple of things on that. So obviously I won't be here the 8th. I may or may not record something for you. Just depends on how far along we are for the 8th. So we're just going to be here 4th for the blood lab and for whatever lecture material, and the 6th for whatever lecture material is coming along. Of note, and I don't know how many of you folks are going to be, it's up to you. My wife has informed me in no uncertain terms that I will not be here on the 8th of April because she wants to eclipse. She is eclipsing. Last year, in 17, she went with all of her kids, at least 4 of the 5 kids, and camped in the Smoky Mountains, which apparently was a prime viewing spot for the eclipse. Don't ask me. I mean, I saw it here. I was looking from the casino. Just, are you going to go? No, I think I'll stay here. Not that I go there. I don't go there anymore. Good reason. So this year we're doing a big day trip. Oh my God, I can't believe it. Nevertheless, that's another little announcement on a particular day. I'm starting to get people with topics coming in on the report or the presentation. Please make sure, think about it. Let's try to get them in latest immediately after the break, because you know what happened. You guys have been around the block enough times. After the break, everything just everybody goes on accelerate. I got to get all my material in and blah 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 blah. So we got what to do. Let's get it. Like everybody's in end of the semester mode after break. It's kind of like after Thanksgiving break, but then you only have 2 weeks. So that's sort of the introductory commentary for today, which brings us back to the end of the blood unit. So I don't have to do a whole lot of preparation other than actually do the blood lab and whatever else kind of introductory material we do with regard to it. And of note, I must have mistakenly ended that presentation, so I'm going to have to re-record a little, the highlight film of this on the clotting factors and what goes on with clotting. I'll do it in a more abbreviated fashion. My questions are relatively straightforward when it comes to test stuff, but we kind of left off here, so that's where I'm going to begin. And understand that there are a tremendous amount of problems. I mean, surely thromboembolic disease is one of the great killers we have here. Again, the underlying factor for most folks is damage to the blood vessels and most of it's atherosclerosis. And everything from diet to smoking to the lack of exercise, all of those things are part and parcel of that package. So it's something that you would only, for folks your age, or maybe as you advance in years over the next 10 to 15 years, you start looking if there's a strong hereditary tendency, maybe for men in their 30s and women in their 40s. If, all of a sudden they're, by history, oh yeah, I have a close relative who died of cardiovascular disease or had an early onset stroke or heart attack, then they start looking. But frankly, from an overall health standpoint, the best time to think about this stuff is now. It's the old ounce of prevention theory that's there. These are an ongoing problem. So again, just to reiterate, a thrombus by definition is a clot that forms. An embolus is that clot or a piece of that clot that breaks off and travels somewhere else. So they're even though, so you must know the distinction in the nomenclature, but since they both can accomplish the same problems, clogging blood supply to a vital structure, we characterize it as thromboembolic disorders. For instance, for that reason, like say in a hospital, I'm sure I shared this with you before, in the anatomy part of the program, when we're talking about TED stockings, stand for thromboembolic disease stockings. So somebody in the hospital who's at risk, and meaning they have to be in bed for a considerable period of time, either pre or post-operatively or intraoperatively, they put those stockings on. If they can't get out of bed, they put those squeezing devices on to maintain flow, because when there's no flow and blood is not flowing as rapidly or limitedly, then there's a much greater tendency for clots to form, particularly in already damaged vessels. Just the way it works. So it's a big problem. That's why we get people up in a chair after hip surgery. Hip replacements are relatively common as folks get fractured hips. We'd have people up in a chair that day post-op, down in physical therapy, learning with walkers the next day post-op. So it's well understood. And someone like me, after major abdominal surgery on not one but two occasions, you have those squeezy things over there. And then certainly the variety of bleeding disorders that are attendant to it. And we looked at some of the background with regard to it, and we're going to end up with some presentations that are going to highlight that particular area. And those are genetically based aspects. Surely we'll look at, you can look at sickle cell and you can look at thalassemias, but the reality is that the hemophilias are really significant. And for those who are not historically oriented like I am, I love that stuff. I love period pieces on TV. So the crown heads of Europe, and we're all afflicted because because basically to stop wars, European crown heads intermarried. So and Queen Victoria, who had like 9 kids, and remember it's typically from the maternal side, being typically hemophilia A being typically a sex-linked transmission. Her children all had it, and they intermarried with all the other. And I don't know if intermarried is the right term, but I mean, so those political alliances were based on crown heads of state marrying. So it was all over the place in Europe. And that is the legacy of the Tsar, when it was basically a descendant of Queen Victoria. And that's what brought on, that was the Tsar who was killed in 1917 in the Communist Revolution. That was that crazy guy who was the mad monk Rasputin, okay, who had this magical power. No one knows what it was. And there's been a lot written about it, both fictionally and non-fictionally, that he could calm the Tsar's son, who was the next Tsar in waiting, who had hemophilia. And what hemophilia did, you got massive bleeds into joints, and the pain was extraordinary. So this poor child would scream all night long, and for some reason Rasputin would calm him. And at that point, then they began to almost have power over what they did. It was extraordinarily influential in the palace, and the Tsar was just that, the Tsar. So it's a very, very fascinating story, historically speaking. Obviously to the revolution, and then you had, and if you're like me, you love that stuff. It's called the House of Special Purpose, which was in Ekaterinburg, which was so now it's got Stalingrad is the name of it now, unless they changed it again, which they tend to do. And that's where they were all supposedly there for safekeeping and basically were assassinated. Okay, during that 1917, 1918. So it's very and if you like the series The Crown, there was an interesting part about that in one of the latter season episodes where they talk about how that happened, because he was obviously a first cousin of George the Fifth, so who was the grandfather of Queen Elizabeth II, Queen QE2. It's very, very interesting. Now, I commented, and so there's a lot of those, and they're worth looking into. For our purposes, yeah, factor VIII deficiencies are hemophilia A, factor IX deficiencies are hemophilia B. Still relevant, but less severe. Hemophilia A is the one classically. We used to have no treatments. When I taught this unit before we had more advanced treatments 20 years ago, we would show videos of people who had him, and they were just learning about blood product transfusion. It was so fraught with problems as we get into the transfusions aspect of this, that they were all worried about using blood products because of the risk of transmitting some type of infectious disease. But now we can genetically make some of these factors. We're more confident with bone marrow transplantation and things like that. And even not engineering, but both genetic engineering and gene therapy to try to resequence so these factors could be made. So there's a lot, it's an area where now it's become eminently treatable. Before then, it was really a horrible problem for folks to have. So it's interesting. So one is they're clotting, one is they're bleeding. DIC, and the two most notable, and this is where I ended last time, were one, birth-related problems where amniotic fluid would enter into the bloodstream. The other, gram-negative sepsis, where a burst bowel or a burst ovary or a burst tube. And now you would get basically gram-negative organisms in the abdominal peritoneal cavity. And you remember back to gram-negative, it's called an endotoxin. We call it endotoxic shock. And what happens is it causes a phenomena that effectively gobbles up your clotting factors. So not only does it cause clotting, but it causes bleeding. And interestingly, the treatment was heparin, because you were in a greater danger of blood vessels clogging and limiting the flow to like heart and brain and kidneys, major organs. So the first goal was to do that, was to be able to reestablish circulation and try to deal with the absence of clotting factors. And I told you we had one of our, my kids were literally their favorite dog, who had an abdominal tumor, died of that. Murphy, the 150-pound golden retriever, who was so gentle, the neighborhood kids would come up and hug him on their way home from school. Very big. We talk about being in bed with a big dog. Move. So thrombi, clot, embolus, that or a portion thereof, etc., etc. And the big one for people who are sedentary for long is pulmonary embolus. That's a big post-operative thing. So for those of you endeavoring into medical or medical-related fields, for years, before we had more sophisticated techniques, like the devices that we used, that's why you were so cognizant. People were in the hospital for several days, taking their temperature. The earliest sign of a pulmonary embolus would be a subtle spike, both pneumonia and pulmonary embolus. Somebody quote spiked a fever, and you used to have that chart at the foot of the bed. You see in all the old movies, and you make a little dot chart, and you draw the lines. And if you have temperature, and all of a sudden you saw a little rise in the temperature, this is so and so just spiked this morning. Aha! You should check every shift, and that would clue you in, so you immediately start to think pneumonia onset, pulmonary embolus. We better do chest X-ray, EKG, because we didn't have a lot of didn't have sophisticated scans or anything like that. That's when I was a resident below these 45 plus years ago. No comments. Thank you. I got one smile. See, Hannah would have had something interesting to say. Maybe not. You can talk about her. She's not here. And so that was sort of the logic behind it. That was there. And so, and you can see all the risk factors are there. That's all part of it. So the idea of being sedentary, and it translates to life. People who are more prone to these problems, it's lack of activity. And I mean, this is, hello pot, this is kettle. You got to get up and move around. I'm doing it more these days than trying to lose weight. I'm on a health kick. Just hopefully it'll last for a couple more years. Be happy. I have a high school reunion. I don't want to go back in and. Gee, I didn't recognize you. Look so skinny. Okay, anticoagulant drugs. Number one, easiest one. Post-op, for many reasons, stents, open heart surgery, coronary artery bypass. It inhibits, we know the mechanism, lowers heart attack incidence by 50%. It inhibits platelet aggregation, start of clotting. I mean, what could be easier? That's the good news. Bad news again, aspirin-based products preoperatively are something that we're all aware of surgically. So for people in pain, and aspirin, frankly, is to me a better pain reliever and anti-inflammatory. And Tylenol has no, if you did not know, aspirin has 3 antis: antipyretic, so it's fever, anti-analgesic, or basically pain, it's an analgesic, and anti-inflammatory. Tylenol does not have anti-inflammatory effects. So that's the limitation that Tylenol has. Well, a lot of times we don't have a choice because of all of that is associated. Typically, the anti-inflammatory is in the category of NSAIDs, non-steroidal anti-inflammatory drugs. All of them have gastrointestinal irritation. They attack your stomach line. Heparin, extraordinarily still commonly used, but it's intravenous in nature, so it limits its use. Coumadin-based compounds, they were the gold standard. The difficulty has always been keeping him at the right level. You would do, it's called prothrombin time. It's a standard blood test. A lot of this is used in long-term care facilities. Okay. And what they would have to do is basically every other day, you would do a blood test to look for what was called a prothrombin time. It would give you a control and a actual value, a patient value and a control value. You wanted the value of the patient to be roughly 1.5 times. So if the prothrombin time was 10 seconds, your goal was to be at 15 seconds, etc., whatever the numbers were. And so you would titrate, which means you would adjust the levels accordingly. So what my wife would do when she was working at a nursing home for 10 years, you'd call the physician or the physician's assistant and say, hey, this is so-and-so or Mr. So-and-so has a pro time of this. These were numbers. So it was a ratio. I and R was the name of the ratio. And basically they would say, okay, adjust the dose to 2 milligrams or 3 milligrams or whatever it was a day. Okay. And it directly affects vitamin K. And vitamin K clotting factors are highly significant. The treatment for an overdose of the warfarin or Coumadin-based ones, and because the oral, they were used so much and easily accessible, was to give people higher doses of vitamin K. Okay? That's kind of the way we look at these things. So they were clotting too much. If you lowered the clotting too much in the blood, they had a greater tendency to not clot, then you reversed it with increased amounts of vitamin K. So not only is there a way of using it, you have to know the way to reverse it. That's part of it as well. These are not as common, but they are common enough that if a physician or a physician's assistant will see these. They're called petechiae. Thrombocytopenia means a deficient number of platelets, period. So the diagnostic, if it's under a certain level, and you might see the absolute level on a blood test, you might just say, oh, platelets are low. So they occur because platelets are low, and therefore we're getting areas that should clot do not, particularly leaky capillaries, leaky tiny vessels under the skin, and depending on how abundant they are, we have different names. Okay, so petechiae, you'll see that image is tiny little dots. Purpura is like they consolidate into big blotches. So in medicine, we see a lot of this. Like everybody knows what a blister is. A small blister is a vesicle. Okay, then you can get a bleb, and then you can get which is a bigger blister, and then a bulla, which is the large blister. So in old terminology, you classified them differently based on the nomenclature that were there. And so there's a lot of things that can lead to this. Damage to the bone marrow of any course, whether it's a tumor of cancerous nature, radiation, very, very common. Medications, very, very common. A lot of allergic responses. And so there are certain allergic, and it's it's one that I won't ask you about, but if you go on a medical road, you'll hear about it. It's called Henoch-Schönlein's purpura. What they do in like derm rounds, and it's very neat. We went to the University of Pennsylvania, and once every month, the dermatologist would bring people in of their patients who were willing, they had nothing else to do, if they were retirees or older, or maybe little kids, and they weren't in school age, and they'd be in a room, and the dermatologist would go room to room, have X amount of time, 30 seconds, a minute, to look at the room, read the chart, and figure out the diagnosis and go room to room. And at the end, they'd have a big discussion about it. It was fascinating to tag along with that. So another one, one of my residents under me had one of these that was hereditary called Majoki's granuloma. A really nice guy. He's gone to the dermatologist. The guy said, yeah. Like that. So concentrated platelets, again, as we start to look in transfusions, our next unit, I'll talk a bit about the pitfalls of transfusions. So here, these are typical petechial hemorrhages. If you see this, it makes you wonder. So again, hives are an indication in immunological phenomena where there's an absence of clotting, where there's a lot of blood because of an abundance of histamine that dilates vessels under the skin, classically associated with allergies and food. I can't even tell you how many times I've seen it. My wife will break out at something like that with certain things. She does. So we've seen that with a number of antibiotics, and she's very homeopathic, naturopathic. She's just not. It's that bowl of supplements that I'm halfway through from this morning. It was there this morning. She'll be at her mom's for 4 days. There are 4 bowls, and if I throw them away, she'll know. She'll know. I'll give you her email in case I mess up, so you guys can. So, other things, liver function, that's where you make all these clotting factors. Okay, vitamin K, hepatitis, cirrhosis. Okay, all of those types of things. So, it's all in there. Here's the hemophilia nugget, 77% hemophilia A, factor 9, hemophilia C, factor 11, and decreasing. It's not to minimize them. And that interjoint cavities, for whatever reason, the traumatic aspect. So now we have the genetically engineered factors, because we used to do transfusions, and there was a really increased risk, as we'll talk about, vis-a-vis transfused blood of hepatitis or HIV. So here, widespread clotting in intact blood vessels, severe bleeding because the residual blood is bereft of clotting factors, and septicemia, typically gram-negative, certainly incompatible transfusions, which we'll talk about ever so briefly in the amount of time we have left, and pregnancy, again, amniotic fluid. So, what do we do? What are transfusions? Rule number one, we rarely utilize whole blood transfusions other than when people have had like traumatic blood loss, big accident, gunshot wound, stab wound. They go into the emergency room and you've got to throw a bunch of blood right in right away. Okay. Once you've restored blood volume, your basic concern is oxygen carrying capability. And most of your concern on an elective procedure, when you're having to do hip surgery, uh, large amounts of surgery where they're in an area in the shoulder where it's very, very difficult to stop bleeding, you're typically using pack cells. You've spun down the blood just like we do in the centrifuge, and you siphon off the supernatant liquid, which is the plasma. And even though there's obviously some liquid and some plasma, because it's a liquid component, you're administering pack cells. And what they found when they began to do this in the 60s and 70s, pack cells were better. Why? Because HIV, and you had less chance of hepatitis and less chance of HIV. And when they researched it, HIV is a disease of white blood cells. That's in the buffy coat. Okay. Hepatitis, typically the fraction that carries that is an association with fibrinogen, which is a dissolved protein in the plasma. So when they said, we're getting less contamination with pack cells and infections, what's the reason? And now we can see where those contaminants, if you want to call them that, those infections were. So again, when you're losing it, the big sign, other than, as I've told you before, is fatigue. You're very pale. You're very weak. Your color looks bad. You look at somebody who you see every day and go, oh my goodness. I can remember going in for a transfusion, hardly being able to get down the hall at St. Margaret's Hospital to the medical unit, which is where they did cancer treatment, and walking in there and they go, oh my God, get a wheelchair, put him in there. We better give you some fluid right away. I couldn't get from here to there. What? Gastric ulcers. I was leaking blood. I've had, everybody, the way I preface is, I've had at least 50 units, maybe more, of other people's blood. Because when you give a transfusion, it's either 2 or 3 units, depending on the severity. I had a whole bunch of 2-unit transfusions. I would sit there about every 3 weeks and get blood. Guess I used to be much less clever than I am now. So I lost 2/3, 60 to 70% of my blood. But because I did it gradually and chronically, I'm here to tell the tale. Okay. So then you have to replace it, whether you're using lactated ringers, normal saline, D5W, some isotonic medium. The lactated ringers, because it has some degree of electrolytic balance, is a very common one. So that's volume, but then you have to deal with red blood cells. So again, whole blood only if significant blood loss, other than, and then we just call them packed cells or packed RBCs, are for oxygen carrying. So blood banks, and you can see, even though the red cell shelf life is 100, by this textbook, 100, 120 days, which is pretty universal. The blood bank's going to keep your blood for a month, maybe a little bit more, depending on their needs. And they always need hard to find blood. And if it's a negative after it, it's hard to find blood, period, end of sentence. If you're O neg, they're calling you every darn day. Hey, haven't given blood in a while. Let's hear it. Okay, and I'll go into that why specifically. So that's because of that. And you say, well, that's pretty obvious. Who would make that mistake? The reality is people make mistakes. Here's the anecdote, not to me, historically. Some years ago, when liver transplants were done by dead donors, you had 24 hours to get a liver from somebody who died. That was the shelf life, even refrigerated and carried to get it to, and there was a whole network. It's called the CORE, CORE network for transplants. A lot of it came out based out of here in Pittsburgh. This was at Duke University Medical Center. This is not Bill's Hospital in Podunk, Iowa. So no offense to Iowa. Okay. They had the liver arrived, the man died waiting for it. Duke is a big network, major hospital, top 10 in the United States by anything. They had another young woman on their list. They said, aha, she met the transplant criteria. They called her in. They're on beeper, half an hour, half a minute away at that time, more beepers themselves. 30 minutes away. They transplanted her that day. She did great. 3 days later, she was dead. They did what any medical student would have thought about first. They didn't check the blood type. Like she was A, it was B, whatever. I don't remember. Totally incompatible. Boom. Would I want to be that lawyer? Wouldn't have to work again forever. That's all right. That's why my sister and her husband go to Europe for 3 weeks every year, and I'm here in Cranberry Township. He is a lawyer. Was a lawyer. So, classically, blood groups are A, B, O. Blood types make positive or negative. That is not all of it. And in sort of to give you a little intro to immunology, this is perfect. Immunology is about antigens. Antigens in the old days meant antibody generating. We didn't understand the immune system. We didn't know as well about cellular immunity. All we knew about was we made antibodies, and antibodies fought infections. So anything that was an irregular or foreign marker on our cells, we thought was an antibody generator. We call them antigens. Now we know about self and non-self antigens. So understand, when you look at what makes blood react, it's the antigens. Antibodies play a role. If you know somebody who had a baby and they had to put that baby in because the baby was a little jaundiced and they used ultraviolet light, that was probably what we call an ABO incompatibility. That probably meant antibodies of a certain type were problematic, but certainly not fatal. The antigens, on the other hand. So we call them agglutinogens because, as you will see in the lab, red blood cells bundle up together because the antibodies interlace them, and they agglutinate. They form little bundles that become visible little dots because there's just thousands of them coming together. Now we can see a visible speckled pattern. So any mismatched blood, the reason it's fatal is if you have an agglutination reaction out of control, it will clog up your kidneys rapidly and you will die. People have a misconception. If I didn't, I'll tell you again. Back in 1981, when my first wife had her ovaries wedged in the hopes that we were having children, she developed a terrible bleed. They did not know she had a variant of called von Willebrand's disease, we were talking about the other day. And what happened was they gave her blood. She was exposed to Hep C, which they found out 20 years later. Okay. Significant problem, mind you. The blood then was not screened. Post 1987 blood bank blood is the second safest blood you can have. Safest, or your own donation yourself. Second, statistically, blood bank. Directed donations are statistically less safe. That's not because Uncle Charlie was being frisky with somebody he didn't know about, okay? You know what I'm saying? It's just statistically, it's more. Uncle Charlie might have just had a bad radish one day. Who knows? I'm joking. Remember that. Joking. So we have a lot of antigens, but the ones that trigger this massive agglutination reaction are the ones on the red blood cell per se that are most egregious. Okay, and we classify them. So when they do what's called a cross match, when you match up blood for donation, a cross match means that you test for multiple. It's not just AB. That's the first one they do, ABO. Then to do a cross match to find the most compatible blood, they look for all these other ones because they're relatively weak. Okay, and that's what they do for people who need a lot of transfusions, like me. Initially, I'm A positive, second most common. Easy, easy to find that blood. After having like 6 transfusions, all of a sudden I have to go in 2 days early, not the day before or the day of to match my blood. To the point where I said, why so early? He said, well, we may have to go to another blood bank like Buffalo or Cleveland, which are the nearest ones to Pittsburgh, to get blood. So it's because of the vigorous nature of those transfusions reaction. This is genetics. You all had this, I am sure. So rather than go to this, so all of the antibodies form in the blood at about 2 months of age, and by 8 to 10, they're there. So understand this is an ongoing problem. And the best thing is to chart. Without me, I used to draw it, but you guys have had this stuff. So as you can see, they give you some of the demographic frequency numbers that are there, and they vary certainly. So for whites or blacks, the major changes for folks of color, at least as I can see it, is we have less A and a greater amount of O and B, comparatively speaking. Okay, that certainly is an issue that's there, and you can see some subtle variations that are there. What it means is this: if you have, it's by definition multiple alleles. Normally we have dominant recessive. Here we have dominant recessive. That makes it multiple. What's interesting about that is the most common type is the double recessive. Go figure. I don't get it. The least common type is both dominants. And I'm not here to answer why. I know someone who teaches genetics here that you folks could ask. Well, I'm a great admirer for her clinical acumen. Okay? So, and again, it's about the antigens. A and B. A makes A antigens and antibodies to B. And you notice, look at the shape, because it shows you how they're going to interact, why A and B are so incompatible. B makes, you can see the circular antigens with the antibodies to A, the ones that have that spike. AB makes both antigens. O makes neither, but both antibodies, and it's all about the antigens. So what that means is A and B are totally incompatible. Years ago, they called AB the universal recipient. It's probably incorrect because we didn't take into account the RH factor. So RH would be like having another marker of a different shape, like a little cylinder sticking out here. So even though you might have less of a reaction, AB positive is a true universal recipient. Where on this side of why it's the one where you're the most popular person in town, well, the blood bank is O negative, because that RH, or factor D as it's known, doesn't have anything to do with antibodies. You either have the marker or you don't. So O negative has no antigens, A, B, or the positive or negative. And indeed, all the negatives are significant because that is comparatively rare. Remember, it's typically a 3-to-1 kind of a thing because it's standard Mendelian recessive. So what does that mean? Usually it's 3-to-1 if you do the cross. The reality is that people who are positive are most likely to have children with other people who are positive. So the actual presentation in a typical population is probably between 80 and 85%. So it would be, if I polled you randomly, 10 people, 7 or 8 of you, maybe even 9 of you, are likely to all be positive. It would be unusual to find more than 3 or 4 negatives in our class of 16 individuals of all. That's what it means. That's why we begin to see the predominance of that. So there are a variety of factors that are there. RH is interesting because it comes from, we did the research was done on a rhesus monkey, RHESUS, if you didn't know that. Okay, so RH positive is the D antigen, you see the 85%. And we don't make the antibodies. This is the important nugget. If you are female and you're going to have children, you're most 85% of the time, you're most likely to have children with somebody who's RH positive. You have a pretty good chance then of having a baby who's positive. What happens at the end of that pregnancy, however that pregnancy ends, whether it's with a birth, whether it's a spontaneous or an elected termination, without getting into the political ramifications thereof, when that pregnancy ends, somehow, some way, the mom is exposed to RH positive blood. And at that point, she starts making antibodies. And that's the sensitizing dosage you'll learn in immunology. And the problem with those antibodies, they cross the placental barrier. And for the next baby, if it is RH positive, they will attack its blood, cause a disease called erythroblastosis fetalis. And that is very often deadly to the growing fetus. Hemolytic disease of the newborn. So the first pregnancy, so we're assuming it's delivery, that's what's going to happen. The second pregnancy, the antibodies, which are already starting to form, which are there, will cross and attack that. So there are treatments that are there. Every doctor who's going to deal with somebody who's pregnant, if they get any kind of medical intervention at all, is going to be aware of that and institute the RhoGAM serum. The anti-RH can prevent RH moms from first becoming sensitized. So, however, whatever the standard of care is today, that's what will be employed. People, whenever I say that, well, who wouldn't go to the doctor? There are people who don't end up going to the doctor. If you're going to be in an emergency room, going to have an overweight young lady, teen, who's going to come in one day and all of a sudden be delivering a baby because they didn't want to tell mom and dad. That happened twice, once a year for 2 consecutive years in our emergency room where I was a resident. I don't think it's changed that much. Now, I am an authority on teenage girls getting pregnant. Daughter, granddaughter. So again, agglutinate, clogs, hemoglobin, kidneys, yuck. All of the above. Fever, number 1 hip rate. That's another reason why we're so advanced. First thing they told me, after I had a training, come home, we want you to check your temperature every half an hour. If you have a temperature spike, if you feel sick, you get the chills, you call us now. You're going to have to come back. So fluids and diuretics wash out the hemoglobin. Again, that's it. Autologous, pre-donating the blood. You know you're going to have a hip transplant. Hip prosthesis, artificial hip put in. You might put a couple units on board, a month before. Major plastic surgery, you might have to do that. Some kind of reconstruction, you might have to do that. So we're going to do this. And so again, we end up when they mix with antibodies against common ones, you look for the factors, and the cross match is very specific. That's what they'll do at the blood bank when they ask for blood. Most hospitals have a rather large supply of blood, and they work in concert with the local blood bank. So, and again, every time you get someone else's blood, you make up antibodies. Okay, that's why every successive transfusion after that becomes increasingly more difficult. It makes the cross match harder. You don't have to type it. Your blood type doesn't change. So originally the order is type and cross match. After that, for subsequent transfusions, you need only cross match. Blood type isn't changed. That's perfect. And that's what we look for. We'll see that in the laboratory and all of these types of things, the different things. And we'll be doing all this in the laboratory. And we're looking for any abnormalities. Again, this is the differential. We're going to actually do one in the old-fashioned lab. We aren't doing proton or platelet counts. I'll be happy once again to show you my wonderful blood tests. Like, they call it CMP or BMP, basic metabolic panel, my CBC, etc. And we're done with the blood. So I don't have to start respiratory until Monday. Thank you. Have a wonderful weekend, all of you out there in virtual land.